And today we're going to talk a real sensitive subject, I think. Logan Health pediatric hematologist and oncologist, Dr. Rachel Brennan. Good morning.
The doctor is
Good
in.
morning.
Hi.
How are you?
Good. Wow. Why hematology and oncology?
It's a great question. It's one I think probably every pediatric oncologist gets asked multiple times.
I'm guessing hematology has to do with the blood, right?
It does. You're right. And there are blood cancers and there are things that are not cancer that are in the blood. So we actually see everything on either side. Today we're talking mostly about oncology. This is September. It's Go Gold for pediatric cancer. So raising awareness for pediatric cancer is one of those things that is really important this month. When I was in third grade, I wanted to either be a rock star or a doctor. And, I played violin, and so the rock star bit was kind of a little not going to work for me. And I didn't know kids growing up who had cancer. I grew up in Helena, went to Carroll College, and it was during college that I began to have some exposure to pediatric cancer. I was able to shadow an oncologist down in Denver for my biology thesis research that I did junior year. And just became, it was just one of those things that said to my heart, you have to do this. I love kids. I love working with kids, and making a difference for these kids and their families just became what I knew I had to do.
Now, when you say pediatrics deals with under 18, I think, right?
It does, for the most part. Now, if you're, 17 and you're walking into our clinic for the first time, we're going to see you through your journey. Okay. There's an age range of 18 to about 39. That's adolescent, young adult.
Okay.
And so that is another group of patients that really has a very specific need as well. That's going to cross over from pediatric cancers into some of your adult cancers too, including breast.
So how young of kids do you see?
We can see them from birth on.
So where did you go to get your training after Carroll College?
So I went to medical school at Johns Hopkins in Baltimore, and I stayed there for residency. And then I did a fellowship in pediatric hematology and oncology. And my husband was desperately trying to get us back towards the mountains. But as far as I could get was Memphis. And so I was at St. Jude in Memphis for 3 years for fellowship.
Oh, my gosh.
And then it sort of fell into my lap to be able to be the clinical director for the retinoblastoma program there. And so when you talk about opportunities and what you're involved in, I said, well, this isn't my mountains, but at that point, there still wasn't enough support in Montana really to not be the only oncologist, and I couldn't be the only oncologist for the entire state.
Yeah.
So over time, and with the advent of Logan Pediatrics, now we have, I'm one of 3 physicians here in Kalispell, and then Billings Clinic has one as well. So now you're not alone. And I think that really helps as an oncologist, but for our families to know that we have this breadth of experience for people who have come back to Montana, who've done training elsewhere, and have been able to come back to Montana and are fully supported here to be able to take care of kids in Montana.
You mentioned St. Jude. Robin and I have a history with country radio, and we're very involved with Randy Owen and Alabama, and of course the country radio support for St. Jude. And I got a chance to visit there. It was about 20 years ago now. What a facility!
It's amazing.
Yeah,
it is.
It just amazes me that they actually have success with these kids who are so terribly sick.
They are, but they're also terribly resilient, which is wonderful. And so when I came back to Montana from St. Jude, from this place that really is world renowned, everybody knows St. Jude, everybody's heard about St. Jude. I came to Kalispell and I thought, okay, well, let's see what we've got here. And I'll tell you what, we didn't skip a beat. The access that we have for care and support here for all of the multidisciplinary pieces that I need as an oncologist to be able to treat these kids. The surgeons, the PICU, the hospitalists, the inpatient teams, the nursing, child life, social work, housing, resources. We actually have it all here as well, which is absolutely impressive.
Wow.
But that's why we can keep the kids here.
Now, St. Jude was kind of on the leading edge years ago with kids from all over the country. They had the problem going there. But now they can be treated here locally.
They can. And we still will rely on centers, St. Jude, Colorado, Seattle, all of the big academic centers that you think about for them to be pushing cures and pushing research for these kids. But we can treat kids at home with the knowledge of what we have already, what are the standard regimens that actually have cure rates, 80, 90% for these cancers now. As a result of all of that. It's not true for every single one. But my goodness, I'll tell you what, parents walk in and they want to know, and I tell them, your kid's not a statistic. Your kid is 100%, and that's what we're going for here.
So let's talk about these cancers that kids get.
Yeah, they definitely fall in some different categories compared to adults. The most common is going to be leukemia, which is a blood cancer. Probably about 25% of cases in kids, and then another 15 to 20% would be lymphoma or cancers in the lymph nodes. Brain tumors or tumors that can happen anywhere along the brain and spine would be about another 20%. And then the rest fall in this category of of solid tumors. And so you can get a solid tumor anywhere. That could be in the eye. So knowing the glow, if you see a glow in your child's eye or you think your child isn't seeing properly, that's something to look at. Kidney cancers, muscle cancers, liver cancers, bone, nerve cell tumors, germ cell tumors, basically anywhere in the body. We don't tend to see breast. We don't see prostate. Those are more adult lung cancers. But, being aware of the different types of cancers and then also knowing at the end of the day, what I do and what I see every day is my 100%. It's not rare to me, but pediatric cancer is rare. When your child has cancer, it's no longer rare. It doesn't matter. I can give you all the statistics in the world. And so just, knowing your child and be able to have a conversation with your primary care provider if you see something, that you're worried about, that's what we need to know about.
A young man, a boy, a friend of mine when I was growing up here in Kalispell who had leukemia. And, we knew that it was a death sentence. We knew there was no way out. They gave him some medication that made his face get big and round. And of course, we were told, don't make fun of him. And I looked at that, and the poor guy, he felt terrible. He looked bad, and he died anyway.
And that's not the case anymore. No.
I just wondered, why go through that?
Right.
If you're going to die anyway, but
it's changed so much. It has changed so much.
How did we get to a point where we can cure something that was a death sentence just 50 years ago? So
it has to do with the research, and the research that we talk about is both at the bench and at the bedside. So yes, there's research in test tubes looking at these cells, trying to figure out what new drugs or targets, especially immune therapy, trying to use the body's immune system to attack these cancers. But then also doing bedside, which is taking these therapies and saying, okay, we need to compare, is this better or worse? And that's a clinical trial. And those are most often run at larger academic centers through the Children's Oncology Group. And that is a group that is nationwide with all of these centers. And so you take a very rare cancer, and now you take all of those kids with that rare cancer, and you can actually understand their outcomes better, and you move forward. So for example, with renal tumors, the different studies over the years from the 1940s, 50s, and 60s through to today have now made kidney cancer, Wilms tumor, one of the most curable cancers. And not always do we have to take out the kidney. The other thing I think that you bring up a good point is, going to school during treatment. And I want to emphasize that, yes, cancer does not stop life and will not stop. That is our goal. It does not stop. It changes how we do things. But these kids are thrivers. And yes, they can go to school. And I think we have seen communities come around these children and these families and be so supportive. And yes, they look different. Their hair is gone. They may have puffy cheeks, most probably from the steroids. But at the end of the day, they just want to be kids. They just want to keep moving and living their life. Gosh, when they feel good, they just go 100 miles an hour, and their moms and dads like, whoa, your platelets are low. You're going to get a big bruise. Hold on, slow down. You can't slow them down. That's the best part. And being able to see that and to see it longitudinally. I think that's the other reason I went into pediatric oncology, is because you develop these relationships with these families, just like you would have with your pediatrician for 18 years. We really are their physicians for life too, not just during therapy, but because once therapy stops, you have to still deal with that footprint that you made on the child, right? To get cancer in remission and out of the picture, now you're dealing with some of the late effects and side effects, but we're learning more about that too. And so research on the survivorship side and really what these kids need as young adults to be able to live not just to their 5th birthday, but to their 105th birthday, right? Like 77 is the new 50. Come on, they got ways to go.
Well, as far as I'm concerned, it's the new 20, but what should parents look for? I mean, your kid seems fine, but inside them something's going on.
Right.
What clues can we look for?
Sometimes there are clues, and sometimes you just find it. I think, there are some signs to be aware of. Like I said, know the glow. If you see a white glow on one side of the eye, not on the other, instead of the red reflex, the camera usually would do, that can be a sign. If you feel a lump or a bump in the belly, that shouldn't be there. If you feel a lump or a bump in the arms or the legs, that shouldn't be there, especially something that seems to be growing or more painful. Seeing more bruising, fatigue, paleness, petechiae, these little tiny red dots. And then I also want to emphasize that each one of those things doesn't have to be cancer. So that's the tricky part, right? Yeah. And, kids can't always tell you that they feel bad or whatever. And then if they do, the next minute they're okay again and they're running. So I think, I don't want to scare parents. I think it's just raising awareness that this can be a concern. And if you see something, say something, go in to see your pediatrician. And if you end up in our office to come talk with us about something, it doesn't always have to be cancer. But if it is, I want to say that we're here to be able to help through this journey. And that is for all of Montana. We see and treat kids here in Kalispell with their chemotherapy infusions. I know Dr. Breeding also does that in Billings. Those are really the 2 locations because that's where we have our oncologists to be able to oversee those infusions and anything that would happen. But we travel to Missoula, to Bozeman, to Helena, and to Great Falls in outreach. I was actually just in Great Falls yesterday and seeing patients. Now, most of those are going to be off therapy patients for oncology, or maybe some of our hematology patients, but we can travel to them instead of always having to have them come here to the Valley.
KGEZ's Glacier Bank Community Conversations, a good one this morning with Dr. Rachel Brennan, Logan Health pediatric hematologist and oncologist, and the oncology part is focusing on cancers and how they affect kids. I guess finding cancer at the earliest possible time is always optimum.
Oh, absolutely.
And is that true of all types of cancer?
It is. And at the same time, I think, you can never go back and say, how big was this cancer 2 weeks ago? You're never going to know. You have what you have in front of you. But regardless of the stage or the age, right, that is... we have options, and we can do, for the majority of our patients, we can treat them here in Kalispell.
Okay. Now, mothers really love their kids. They go through pregnancy with them, they deliver them, and so they observe and they kind of know when something is not exactly right. Something's bothering the child. Typically, would they be dealing with their pediatrician on
Starting
this?
with your pediatrician or
Okay.
your family medicine doctor. And I have the utmost respect and profound gratitude for them because they see everything that comes in the door. And honestly, most of the time, it's hoofbeats, right? Our horses, not zebras. But I am the one who will be involved if it is a zebra, if it's something that is more rare and needs more attention.
Okay.
But if they have any questions, those pediatricians and providers can always call us. That's the other piece.
That's what I wondered because, I don't have the answer to it, but we'll check into it.
So, is there an end to all this?
We have made profound strides, and I think the hope that I have in our ability to continue moving forward, a lot has to do with my time that I spent at St. Jude because I saw some of those cures being moved from the bench into the bedside. I saw the changes in the kids, and I worked with people who had 20 years ago had the experience, that your childhood friend did as well, and have been able to see that change and onto the other side. Just recently, there was an addition of an immune therapy into the leukemia treatment plan and protocol in 2 different blocks, and that has actually been the newest and most recent increase in survival for those leukemia patients is using that immune therapy now up front. So we continue to see incremental changes every day, but it's not just the hope that I have in the research and in finding new cures. and the people who really support that, the philanthropic, support, really that comes for pediatric research, because it's not usually as heavily funded on a government level, let's just put it that way. So there's a lot of philanthropy that comes through that, St. Jude donors, things like that. But I see hope in our kids and our families. Every time they come through the door, I mean, that's why I come to work every day, right? And my colleagues that I work with, both in research, the passion that everyone has every day, there's no reason you would keep coming back to this if you didn't sincerely love it and want to make a difference and know being there every day made a difference.
There's artificial intelligence is that affecting your world?
Oh, I think it affects all of medicine.
Yeah.
Where I have to sort of decipher what AI told the parent before they came into my appointment. That's one way to do it.
Yeah. I'm thinking of some of the research that's going into these things, the ability to really pull in. One example was brought to us, DNA.
Absolutely. I was just going to say the genetic piece.
Thousands of DNA. Mm-hmm. Do you think it's even possible that we could prevent these things genetically?
Well, only about 8 to 10% of cancers are inherited genetically. I think the other ones are gene mutations that happen because of some exposure or something just kind of goes wrong. And so if you could go back and fix those, some of those we're doing with genetic engineering and some of our thalassemias or the blood or hemophilias actually, for being able to change the gene that went wrong. I would love to. I don't know how that's going to work out, but I do know that, the exponential growth is just going to continue.
Okay, now I had a question. John mentioned growing up with a boy that had leukemia and Red Skelton's son, Red Skelton, the comedian, who was married to a flathead girl.
Yeah.
His son had leukemia. But when I went to grade school, I think I was about in the third grade, and there was a boy who had bone cancer. Mm-hmm. We tend to think in adults, bone cancer is a progressive stage of something going on. So what kinds of cancers do you see?
So, yeah, we see everything. Bone cancers could be either a bone or a bone and soft tissue type of a cancer, or bone and muscle. And the difference is the way that they present in adults versus the way they present in kids, and then the way they respond to therapy in each of those populations is different. So the biology of these cancers, of an osteo or a Ewing's or a rhabdo in a child, is very different from the biology in adult. Where those in an adult are probably because you've picked up lots of environmental exposures or just regular throughout your life. Whereas in a child, the genetic fusions can be a little bit different. Again, it's a genetic fusion that happened in one cell that went bad that caused the cancer, not in the entire child.
Well, I'm glad you know what you're doing.
Boy, am I.
Yeah.
Dr. Rachel Brennan, thank you for, first of all, clarifying a lot of things and also giving us hope.
And
Absolutely.
You're very passionate about your pursuit.
Absolutely. These kids are amazing. Thank you for having me.